Our next speaker, who is Mr Noel Mulvihill, and Noel is the HSE Assistant National Director for Older Persons and is also the National Lead on Health Services for older people.
Thank you, and thanks indeed for the invitation to be here this afternoon. I know you've had a lot have been spoken to, so I'm one of those people who are keen to listen to yourselves. I suppose just I would like to welcome the document and particularly the authors, because I think it's a huge, important piece of information. It gathers critical elements together, which we've had at various different areas previously, but this steps it from the whole continuum of care for dementia care, from very much from the community to primary care to acute services, residential care. So it's hugely important that we have that document, and it challenges us all, particularly ourselves as a provider, as Tig has mentioned earlier, from a private perspective, from our voluntary service providers. There are lots of the challenges there for how we do our work and how we need to reorientate our work. But also, I suppose, it highlights it as well, because it's a specific area that requires a specialism and requires an attention as well by ourselves, not alone when we are planning. I mean, as Geraldine has alluded to about the strategy of this year and having that information there and how we can actually work through that and make a difference in how it's done. Just to highlight the challenges, and it's interesting reading through the document of what actually is there. There is the mindset there of what we're actually talking about and how that needs to shift and how we can actually overcome that, even particularly with our own services. Even within communities, the level of a sense of how the service should be delivered. The medical model of care as well is another one that we need to, I suppose, challenge to some degree. Need to look at the medical versus the social care, those components that are there. Innovation and collaboration, resources. We have resources. One would say, have we enough for resources? We never have enough resources, but there are resources there for residential care, for home care. How can we, I suppose, effect opportunities with those current resources to change the model of our service and to make a real change in how it's done. A structure for action, it does need a pathway, there's no doubt about that. It needs a clear integrated care pathway, and looking at it from the point of view of the community, acute and residential, as I said earlier, so that it actually can be built together in that way. Lack of dementia-specific information, we do have that in the fact that we're not collecting it at present. And we look at then, let's say, what we have done. There are variables there about the increase in home support services. Geraldine has alluded to the single assessment process, which is critical. We have commenced work on that in the past 12 months. We're trialling it at the moment in both a rural and an urban site. One of our issues and complexities in this country is the multiple assessments that are out there. How can we agree on one single assessment? We're trialling Inter-Ray at the moment in 2 sites, working positively out of thought. It's a huge shifted mindset. It's a huge amount of work for our frontline staff. So we need to ensure that we work that through again, through the various different areas, through primary care, through community services, through residential care, through acute system. So we can actually eventually end up with a system and a process that works for all. A register of people as well with dementia. Obviously a register, we have various different registers in this country. A register that clearly defines the need, but obviously the single assessment process will bring us to that space as well. Integrated clinical care programs across primary. We have the clinical director program, which works out well. We have it in various different areas. If you look at acute medicine, if you look at cardiology, it has given us a consistency of approach rather than the variables that have existed amongst the various different acute hospitals. For instance, we have over 50 acute hospitals in this country, and we have a variability of how you actually treat people. Clinical director programs gives you a consistency, a one system approach in how that should be done. We've done that through home care packages. It's about standardising it. It's about standardising it, and it's about a knowledge that regardless of where you are in the country, that you should understand this is the type of service you're actually going to experience. That does create some rigidity as well, and we need to be aware of that, and we need to be aware of how that has to be challenged when there are issues there. And I suppose it's the palliative care for people with dementia as well. Roughly, I suppose, just briefly, the education and learning, some good education programmes that are there, some that are being developed at the moment with our own frontline staff. And I think that is about awareness, but this document starts that in lots of ways. And it's about how do you develop that awareness and bring it into the point of service delivery. Case management, we've spoken about case management previously, provide individualised support for people with dementia and their carers, and exploring the various different models like Hugh was outlined through the Genio project. I think there's huge potential in that, because that's about putting it out into the areas. I mean, it's interesting to see what's returning from the various different areas around the country. There's a real interest from our own frontline staff, from both the private, voluntary, community and statutory service provision. And that's what it's about. It's about encapsulating that and saying, well, looking at various different models within that, looking at a community model, looking at a residential model, and looking at, I mean, it's interesting to see our colleagues abroad saying how hard it is to change. But obviously if that comes from the ground up and they have a real thought there and they have a sense that this can actually be done, and to populate that through the system, I think there's a lot of energy behind it. Certainly what I've been hearing from on the ground, people are genuinely interested, and if people are genuinely interested, I think change can be effected quite easily. And learning from other care groups as well, because that's important. If we look at our colleagues within the mental health and disability, they've been through various different areas in this previously. If we look at the level of institutionalisation, which slightly concerns me, I suppose, in our numbers that are constantly increasing in long-stay care. And our challenge is, as you know, we have said from a corporate perspective, from our statutory point of view, that we need to look at reducing that number. And obviously, if we are going to effect change in that, we are going to have to look at more community supports, a reorientation of our service delivery towards the earliest possible point. And again, it's about that earliest possible point around diagnosis, around availability of services and community supports, but also community supports to families, and not just a sort of a piecemeal kind of thing. Well, you might get a bit of this, or you might get of that, and almost a contractual arrangement with the family to say, if these are your needs, how can we assure that we can deliver that over a period of time? And that, I think, is the only way that families can actually begin to work with us then, and we can deliver and do the job together. Acute care, again, it goes in the document about acute care. I think it's a critical point, because it always concerns me, and we're working more closely with the special delivery unit now established directly by the department and the minister around that. And I think that's particularly important, frail elderly and how they're dealt with in the acute hospital system. Indeed, from the moment they enter our emergency department, how they're dealt with, and that we need a specialism around that, and we need a special awareness. And it's interesting to see that that's actually beginning to come into some of our acute services. The integrated pathway of care around and discharge protocols. Again, that discharge element about it, that level of reassurance for families and support that they require for them to become a partner with ourselves in delivering the care. And again, the point about replicating good practice. Residential care, again, the importance of it, and has been alluded again previously by our speakers around new models. We have to look at new models. The small-scale living, the housing with care, there are variable ones that are there, and I think we do need to examine them, and we need to examine the cost around that as well. But also, let's say, for instance, the challenges that are there for challenging behaviours, and how we can ensure an appropriate facility for those that actually have challenging behaviours, and begin to work through that. Consultation, advocacy, listening to people and what they want, often about continuity and flexibility as much as volume. Continuity is critically important. I mean, we have to learn this through our own home care services, looking at what type of service we deliver, the continuity that's actually required there, and expanding advocacy services, which are critically important, because advocacy is about giving people a voice, and there's always a sense that particularly people with dementia, they don't have a voice, and generally they don't. Everyone feels that there's somebody else to speak for them, or that they know best. Conclusion is just building on what is working well, and there are some elements that are working well, but collaborating with both the department, the Genio project is outlined, which will bring real change and can give a reflection of good practice, which obviously can feed into the strategy, and working with people with dementia and their carers, which is critically important, the statutory and then non-statutory and voluntary groups and professionals overall. Thank you.